was uh, was a challenge for us because it's not. I'm so sorry. Okay, because it's not this infectious is not common here in Peru. So the diagnosis approach was very interesting for us because we don't initially we don't consider this diagnosis, but in the evolution to evaluate the risk factors, and we obtain the final diagnosis. Okay, this is the 90-year-old male from Lima, Peru. This was born in Lima. Presenting a 4 weeks history of subcutaneous lesions. This history has 2 parts. No? In the last 5 months return to Lima, this guy lived in US, specifically in Maryland. No? 7 weeks before admissions, the patient referred the wells in the right low quadrants in abdomen and internal face of the left leg. This is only 2 lesions. In the first stage, like a rash. 3 weeks before admissions, the wells, the rash, this was the initial lesions, become into a painful pruriginous subcutaneous infiltrate lesions. Is the more the more large, and the patient referred the painful, but very interesting is the aspect and the consistent is the infiltrate lesions in this area. When the patient returned to Peru, with these skin lesions, the patient went to consult with a dermatologist, and the first dermatologist prescribed mupirocin, clindamycin, and naproxen. With this first antibiotics course, the patient don't refer improving. So 3 weeks after, 2 weeks after, the patient went to another dermatologist, and this dermatologist prescribed a new antibiotics course, for only 1 week. It's very important to notice in US, this patient don't consult any physicians. Okay, that's only he see the evolution in this time. Okay, when the patient here in Lima, after two evaluation with dermatologists, the patient was admitted in the Clinica with hope because it's for this chronic or subacute or chronic subcutaneous lesion. As I told you, this patient was born in Lima, Peru, and lived in Maryland, US, in the last 5 months before return to Peru. Central in Maryland. Specifically in Maryland, he worked in the market. In Peru, he is a college student. Apparently, he traveled to US to work in any activities. Okay. In the past medical history, the patient only referred asthma. The patient have allergy, with seafood only. Patient don't receive chronic medication for any disease, even for asthma. He didn't take aerosols or another treatment for asthma. And no use drugs. Apparently, no history TB in his family or university classmate, but it's only of the patient report, is not totally true, because in Lima, Peru have a high incidence of tuberculosis, in any district of Lima. Okay, but apparently done history TB or TB contact. The physical examination, the signal vitals was normal. The patient is alert. The Glasgow Common score is normal. 15. But the skin lesion is that the patient presents in the first evaluation at admission in the clinical with hope, the painful pruriginous subcutaneous infiltrate lesions, in this area, in the right lower quadrant of abdomen, and in the left leg. No abdominal pain, no visceromegaly, and the rest of the physical examination was not contributory. This is the, I'm sorry, Samuel. First is this picture, and then the labs. Okay, this is the lesions. As you can see, this is the lesion in the right low quadrants. Here, this is the erythematose, and in some area is the purple color too.
No pytam, czy są jakieś dziewczynki.
Okay. Yeah. Okay. And as you can see, this patient have a scratch because it's the lesion was pruriginous. Okay. This is another picture here. And this is the lesion in the left leg. And you can see it's the same. It's erythematose. Pruriginous lesion too, and the consistent is the infiltrate lesion when we palpate this area. Okay. The lab result is apparently normal. In leukocytes was normal. The differential leukocytes, is normal too in neutrophil, eosinophil, and lymphocyte. The platelets was normal too. The liver test function was normal too. The creatinine was normal. CK, creatine was the CK was normal, and C-reactive protein and procalcitonin was normal too. I'm so sorry. The C-reactive protein was abnormal. It's increased. The normal value in our lab is the 6. Obviously, is increased. This is the lesion. Until now, you need more data, or you decide to start the discussions, the differential diagnosis in this case. I don't know from US, from Dr. Antonio Villegas. Okay, doctor, go ahead.
Hi, good. Sorry. Hi, good morning. I have a few questions. The first one, you told us that when he was in Maryland, he was working in a market, right? But what kind of market? A food market, a seafood market? What was the characteristic of this market? Because I know Maryland is a coastal city with near in the sea. Well, near the sea. So, what kind of market did he work in Maryland?
No, it's a common market with a different products. It's not specifically seafood. It's like it's not Walmart, but it's like more Walmart. Okay, no specific product of this market.
Okay, okay. So when he went to the U.S. to work, obviously he went legally, so he was staying I assume in a house or in an apartment, right? Did he refer there any contact with any animal, specifically any amphibious animal, or contact with fish or something like that?
Yeah, this is a good question. The patient referred he worked and he lived close to the mountains. Okay, so he walked with his dog, no, in the afternoon, no, in these mountains, no, it's close to the mountains. It's only that. The specifically contact with another animals, no, no, apart his dog, not. But it's very important
So,
he contact with the mountains, you know. Mhm.
so he do outdoor walks and things like that. Did he refer at any point any tick contact? Any
Good
tick?
question. Apparently, he don't refer that. So when we ask this question because as we saw specific diseases in this area. Apparently, he don't refer that. Mhm. But he referred the contact with this area, no? The mountain rural area, is because it's close to the market when he worked.
Okay, okay, okay. Right now I don't have more questions.
Okay. I don't know if, from Chile, from US or UK have a differential diagnosis, or you need more data.
There is a question in the chat. Any bites? Any history of bites?
Apparently not. He didn't refer that. But it's a good question, no? Because there are specifically disease related to the bites, no?
I have a question. Does the patient shave that area?
Shave?
Yeah, shave.
Not specific. No. I don't remember. No, this is the patient. No.
Any traveling to the lake areas? I know Maryland is at the west coast, but entertainment travels to,
Okay.
I don't know, other
No,
areas.
this patient
I'm mainly thinking in cutaneous endemic mycosis, maybe some kind of blastomycosis, this kind of infiltrating lesions, erythema, and septal lesion could occur as a primary manifestations of blastomycosis.
Excellent comment. Well, for example, if in Peru, when we approach this kind of patient, from jungle, we consider, for example, paracoccyomycosis or histoplasmosis, TB, because the skin manifestation of the subacute and chronic disease can see same to this patient. For the reasons that we consider anonymosis in this case, yes, but apparently this patient only live in these 5 months in this area in Maryland. Don't refer the travel to another area to the north or to the south.
So I have a comment. I mean, I have noticed in the CVC that the patient has eosinophilia, I think 7%, which is significant. I mean, the patient had a history of asthma. Maybe that's what could explain the eosinophilia. But I mean, if we want to put things together, conditions plus eosinophilia in a patient with a subacute presentation, I mean, endemycosis, specifically coccidioid mycosis, makes sense. I mean, the patient did not live in an area that is endemic for this pathogen, but I mean, I guess for the discussion, we can include that, or for educational purposes, I would say. The other endemic mycosis that we can consider will be histoplasmosis. And some things that come to mind will be in terms of subacute chronic presentation of skin lesions will be non-tuberculous mycobacteria. And I mean, these are waterborne organisms. I mean, cutaneous manifestations can occur. So we have, in Peru, it's endemic for tuberculosis, but here is more, we have more mycobacterial abscesses, cheloni, and all these rapid growing mycobacteria. So I think that could be one of the manifestations. It doesn't look like this specifically. I mean, the cases that I have seen are not itchy, but I think it's something to consider. The other, when we have patients with skin lesions and eosinophilia here, the parasite that we think about will be strongyloides. In Miami, we have cases, I will say, is endemic for this infection, and we have seen a lot of cases in immunocompromised patients. And so strongyloides, I think it's called cutaneous larva. So can present like that, and it's very itchy. I mean, the location is not typical, honestly, but that's something that we can think about. And the most common organism that we have here in the USA that actually causes skin lesions that we have to consider always as a primary infection or maybe superimposed bacterial infection is MRSA. So I wouldn't rule out these bacteria at this point. Thank you so much.
Thank you very much. I note the possible diagnosis. Yes, we consider this diagnosis, but obviously this not typical lesion for any disease, no, in two localization. No? So, Dr. Solar, Sebastian.
Yeah, thank you, Jorge. I would like to add also the idea of skin lesions, subacute presentation, and eosinophilia about larva migrants. The patient has this seafood allergy. However, we should include on the differential and broad thinking about natostoma, for example, or other parasitic diseases that might migrate. This has multilocus. This has not the linear pattern, but should be on our mind. I also agree with all the other differentials that all participants mentioned before. And I think it's important to characterize the subcutaneous pattern of the lesion, at least with an ultrasound. And also brought the differential. I mean, we're talking about infectious disease, but sometimes cutaneous lymphoma, or vasculitis, or erythema nodosum of other autoimmune or inflammatory origin may be seen similar to this, but also is located in two different areas, and it's not specific, and it's not disseminated as a lesion. And other important thing is to classify the patient as immunocompetent or immunocompromised, because if it is immunocompromised, and especially thinking about HIV, we may see some atypical presentation of some of the diseases we were talking about on this differential diagnosis round.
Thank you. It always is very nice to listen your differential diagnosis, because you propose the diagnosis, but that we do consider in the case. No, excellent too. Dr. Adrian Estepa, thank you. Go ahead.
Hi, yes, actually being from the Northeast US originally, when we see subacute skin lesions, sometimes we think about tick-borne illnesses. So may not be classic, but you could have longer presentations for Lyme disease, anaplasmosis, babesiosis, ehrlichiosis. So something that when I was in residency, we always were taught to look out for, being from that area.
Okay, yeah. Excellent. So, well, I don't know, Dr. Villegas?
Yes, another differential that we have to think in this patient with this subacute chronic cutaneous lesion, even he has the history of living in Maryland. He's originally from Peru, and he only have been living in Maryland for 5 months by the history. So a diagnosis that I would think is cutaneous leishmaniasis. That will be in this point it will be like disseminated cutaneous leishmaniasis, but that's something that I will think in this patient. Obviously, I will do the ultrasound of the lesion to characterize a little bit more the subcutaneous tissue, but I will be very quick in doing a skin or a lesion biopsy in these patients. It's true that this is not the most typical presentation of cutaneous leishmaniasis because they're not ulcerated, but they can present with this large no plaque lesion elevated, usually with a soft center. So that and because it's from Peru, and Peru is an area with cutaneous with leishmaniasis, I would think about that diagnosis also. And I'm obviously agree with all the other diagnoses that our partners have said before.
Yeah, it's a good option because it's in our experience with cutaneous leishmaniasis. In the first stage, it's more common to see the ulcers, as you told you. But in the chronic or in the after to the first stage, when you have patient with a mucocutaneous leishmaniasis, it's possible to see the patient with an infiltrate lesion as these lesions, but it's obviously this lesion is more small. It's not large as this patient. Okay, no, but it's good option. Doctor, follow you, Ajoa.
Yeah, thank you. Very nice case. A lot of things have been mentioned, but we should not forget common things. Syphilis is, can be a masquerader and could present sometimes, with skin lesions. So I would definitely want to include the syphilis workup as part of my differential diagnosis. But also, we should also think about non-infectious, vasculitis, as somebody mentioned, switch syndrome, other form of leukocytic vasculitis, they can all present with skin lesion. Even though not typical as this, but because it's infiltrating the dermis and subcutaneous tissue, I would definitely consider that as part of my differential diagnosis. Thank you.
Okay, thank you very much. Syphilis is always is a good option for any condition, but it's excellent for differential diagnosis. Dr. Schmidt?
Yeah, I think I agree with what's so far been said by everybody else. I wonder whether cutaneous nocardia needs to be considered as well, because of these sort of like defined initial lesions and then sort of spread locally, although it's not classical, but I think, as the interesting part, what's been said is, we need to consider what's in Maryland and what's also, what could you have potentially brought in from Peru, and then of course the non-infectious causes. So I think we've probably covered a great deal now of your disease processes. So I'd be interested to hear how you've got to a conclusion.
Okay, thank you. This is a great discussion, for only skin lesion, but this not common lesion. So we discussed this case in this moment, in the last year. We consider any possibility as you consider more possibility. This is great. Okay, we continue with the case with after to that excellent discussion. Okay, we perform any test, try to rule out the possible diagnosis in this case. We performed the blood culture and urine culture, both was negative. We performed quantiferon TB gold to rule out the latent TB, was negative too. ELISA HIV was negative. We always consider Brucella in Peru because the Brucella, same to the syphilis, cause any conditions. So for this reason, we perform the test. In this test, we consider the Bengal rose and tooth agglutinations and dos mercaptoethanol and IgG, IgM for a bilateral flow methods was negative too. We perform rickettsia panels. No, it's very important to consider that because it's when you ask any question about the bites. Even the patient don't refer bites, but it's very important to rule out the rickettsia and listeria. No, a patient walk with a dog in the rural area, no, in close to the mountains, no. We rule out hepatitis B and hepatitis C was negative. So, but we consider the patient from to Maryland, US. So for these reasons, we always remember Maryland is endemic. No, some area is endemic to the Lyme disease. No, Lyme disease was what one option for us, but the lesion is not common. It's relative, but we performed the ELISA. The ELISA was positive, but you know, the ELISA is not the gold standard to test. No, the idea is try to rule out perform the more sensitive and specific tests like Western blot or immunoblot. No? We perform the non-infectious diseases test, no, antinuclear antibody, ANCA, rheumatoid factors, autoimmune panel, no, all was negative, and antinuclear antibody was positive, no, the model pattern. But it's very specific pattern. It's not specific, for example, for lupus. No, you remember the lupus have another pattern, homogeneous pattern. But it's possible to see this this positive in even with infectious disease. Well, until now, in this stage, you have another approach with this result, with this clinical picture. No? Follow, so Dr. Follow. Go ahead. Sí. Dr. Follow, go ahead.
Yeah, I don't know if Dr. Falou has an additional comment or it was just from the previous one that was the hand was raised. But I think Dr. Villegas has something to
Yes,
say.
Dr. Villegas, go ahead.
After this World Cup, some of the diagnoses are kind of ruled out. But right now, the best approach is do a skin biopsy of the lesions. That will be right now my next approach, and probably all of the listeners are agree. This will be the best approach right now after all these tests.
Excellent. Another opinion? This, we think, thanks to Dr. Villegas, no, we perform a skin biopsy and we perform the Western blot, no, immunoblot to Lyme disease, no, Borrelia burgdorferi. No, we perform the skin biopsy and we perform the Borrelia antibodies, no, by Western blot or immunoblot, no, was performed. We have problem with this the disease in Peru because we don't have the Western blot in Peru. We send to another country, specifically US or Spain. The Clinica Good Hope work with a special laboratory, and this laboratory work to the Spain. So so for this reason, in some opportunity, we obtain the results 7 days after. No, take more time. But the skin biopsy was very interesting. Is another way. No, it's more even is more fast to the immunoblot and Western blot. Well, we prefer that to test. In the skin biopsy, the pathology reports that in the lymphocyte and neutrophil perivascular infiltrate. This is suggestive to the Lyme disease, no? But more specific is the specific stain, no? Is the Wharton starring. In the Wharton starring, we detect these structures, no? Here, no? This is suggestive to spirochetas, no? Spirochetas. So for its histopathology findings, this is the final diagnosis apparently is the Lyme disease, and we verify this result with the Western blot. No, we obtain the results. I remember 8 days, 9 days after to obtain the sample. No, yes, this we have the atypical presentation of Lyme disease. No, we don't expert in this disease. So this is what was terrible in this moment because we take approximately 5 days to 7 days to propose a diagnosis, no, even and because we don't expert. But when we consult to the American physicians, you know, some specifically one friend is the expert from Dr. Stalin Birka Romero, work in New York, and we consider that this lesion is not typical, no, it's a typical lesion, no suggestive to Lyme, but it's very important to consider the patient work in the Maryland is endemic area of Lyme disease, no. Well, this is the Lyme disease in return travelers. I don't know if you have any comments about this diagnosis. Dr. Antonio Villegas.
No, sorry, I leave my hands up.
Okay, no,
before.
Dr. Smith.
It's only 2 in the Western blot, only 2 positive. You need to have a repeat sample really to be, because you have an atypical presentation, number 1. Yes, the patient, I mean, we asked whether bites or tick bites and the patient said no, but we often do find that patients cannot recall potentially a tick bite exposure. And I'd be, you know, we get the opposite. We get patients who say all the time, I've got Lyme disease and I've got chronic Lyme disease. I'm sure Jose will have the same. And but it is just, we have to always be certain that this is Lyme disease. And I think in your patient, yeah, I'd be looking for the histological presentations are, I think, unspecific as well. They're not characteristic, and you've only got the OSC and the P41s as positive. Often we see a much more different pattern. There's a lot of cross-reactivity that goes on. He's got a high, you said his ANA was positive, his background, so whether there is some cross-reactivity there anyway. So, you know, yes, it is definitely there, but as a differential, but it's not my first. And I'm sure you would want to make a comment.
The lab you use in Spain, do they do a separate IgM immunoblot and IgG immunoblot?
IgM.
Do they do an IgG as well, or only if the IgG reacts? Hey?
IgG was performed, was negative too.
Yeah.
How
many weeks since onset of symptoms would that have been at the time?
Apparently 7 weeks.
Yeah, so I would. I mean, it may be early, but I definitely feel like that we would probably report that result as more like an equivocal or inconclusive Lyme serology and say repeat sample required in 4 to 6 weeks or something. The other question I have: do you have access to doing PCR on the biopsy? Would that be helpful?
No. Unfortunately, we cannot. Well, as I told you, this disease is not prevalent here. No, we don't have specifically diagnosis methods. No, so as I told you, we send a sample to another country because it's not we don't have the immunoblood, Western blot. We only have the ELISA. Is the common test here.
I mean, so to be fair, Jorge, we would have probably, you know, in the absence of any other diagnosis of like, we would have treated the patient with doxycycline, but we would have been clear to say to the patient that we cannot 100% rule out, and we cannot say this is definitely, and we will have to repeat the testing to be sure. That's what we would have done in reality with your results.
Okay. Yeah. We started after that this finding, or well, with only I'm sorry, after to diagnosis, we started the doxycycline for 4 weeks, and this patient improved with this treatment. No, the lesion decreased, and currently the patient don't have any skin lesion and any symptoms. So when the empirical treatment was successful until now. No, is the patient we received these patients apparently no so or more or less 10 months ago. 10 months ago. No, is in the follow up in the outpatient clinic, the patient don't refer the relapse or any symptoms until now. Okay. Any comments? Okay, we have a little review.
Jorge, yeah, just a quick question. I mean, did you do a syphilis test in this guy?
Yeah. I'm so sorry. I don't write that the RPR was negative too.
Okay, and you said that two bands for IgM in the Western blot were positive. Is it the case, or?
Yeah, the IgG was negative and IgM was positive by immunoblood.
Okay, thank you.
Yeah, so, but for Lyme disease, I mean, sometimes, you know, some criteria is if you have 2 out of 3 positive IgM or 5 out of 10 positive IgG, that could suggest a diagnosis. So I think Lyme is still a good, reasonable diagnosis in this case, based on the serology results.
Okay. Well, we have two criteria. No, is the histopathology and in immunology titers was positive. Well, so but I agree with Dr. Smith because it's very important to perform the new Western blot or that no to verify the diagnosis in after to the acute stage. No? Okay. Dermatology condition in returning travelers. This is the reason of travel illness, no, involving skin or soft tissue, no, is related to any risk factors, no, travel destinations and a type of itinerary. It's very important the question Dr. Villegas about the activity in the Marylands, no. It's very important to see that this patient walk in the mountains, no, in the fields, no, in the afternoon, probably in this walking seasons exposure to the bites, no, and he don't feel that, no. Underlying medical condition, this patient only reports the asthma, duration to the travel, no, activities during the travel, no, and environmental exposure. No, this Maryland is an endemic area for this disease. In this slide, no, in this review, no, show any disease caused to the skin lesions, no, and Borrelia always is one option, no, because it's Borrelia is common in US. No, but another option is as you mentioned, syphilis, no, but mycobacteria, no, TB or not TB, no. Well, Lyme disease, no, is caused by Borrelia burgdorferi, is the gram-negative bacterium, no. It can culture by the Borbor stoner killer medium, but it's not sensible. No, this group no have apparently 18 genus species, no, to cause this disease, no, the Lyme disease. No, the first description was for this doctor, no, Bush Wald, described the atrophic skin lesions. No, as currently we know is the diffuse idiopathic skin atrophy lesions. No, is present in America, in Europe, in Asia. No, but more cases is in the cluster area, no, the endemic area. In the known area, no, is caused for this kind of the Borrelia. No, in Europe is prevalent too in some areas. No, but as I told you, the Borrelia burgdorferi is prevalent in Maryland, as I told you, no, in this case. The vectors is the Jodes scapularis, but another Jodes is prevalent in different countries around the world. No, for example, in Europe, no, some report is the Jodes ricinus, no, the different vector transmitted this disease, no. Specifically in Latin America, it's very important to consider the endemicity. It's not endemic. For example, in Peru, only one article, one paper reported the cases, okay? But it's not apparently the clinical cases, but apparently it's not present in Peru, no, in the vectors, no, in some reservoirs is not prevalent. Well, but this is some reports in Mexico, in Costa Rica, in Panama, in República Dominicana too, no, Brazil, Argentina, Uruguay. No? Even for only reports. I suppose in the future study, when we perform any test or a prevalence study, probably we discover new areas. But currently, until 2023, no, these countries are report the Borrelia, no, in itself. Lyme disease stage, no, is the localized, disseminated, and chronic. But the localized is the acute lesions, no, in the 5 and 3 weeks after to the exposure to diagnose to the clinical picture. No, the patient have the primary migrants is the more common clinical manifestation with a minimal constitutional symptoms. Even in the early stage, no, it's probably the antibody was negative. Okay, in the disseminated form or stage of, no, the patient have presented another skin manifestation, for example, Borrelia lymphocytoma, no, and the patient present a multisystemic involvement. And then the chronic is the acrodermatitis, chronic atrophiecans is the more common lesions, and patients have more systemic manifestation. For example, arthritis, even the patient have uveitis or no, or eyes lesions and neurological involvement, is very common, carditis too. So in my experience, I don't see the Lyme disease, no, but I treat patients from endemic area, specifically US, with a chronic manifestation, no, is maybe the more common Lyme disease when the infectologists in my country, in front of in the practice. The dermatologic manifestation is erythema migrans is the more frequent, the Borrelia lymphocytoma in the second stage, but another is the lesion like lymphoma too. In carditis, the conduction disorders, palpitations, syncope, dyspnea, chest pain, acute heart failure too are reported. Myocarditis too, but the idea in this case is follow the patient in the evolution as the possible patient reports another manifestation, different to the skin disorders. And neuroborreliosis is very interesting. Is the early stage and the latest stage. In the early stage is probably you see patient with a clinical manifestation for encephalitis or a cranial neuritis too. And in the latest stage, is frequent to the polyneuropathy and chronic meningitis, and myelitis or vasculitis too, is probably seen. The specific treatment for Lyme is doxycycline. Our patient received doxycycline for the 4 weeks, and the patient improved with the lesions, don't develop any manifestations or different manifestations of skin lesions. Another option is cefuroxime, amoxicillin, and ceftriaxone. Is another option that you can use. But in this case, we prescribe doxycycline, and in the follow-up, the patient don't report relapse or another manifestation post-Lyme, Lyme diagnosis. Thank you very much for your comments and your discussions. I don't know if you have the final question or the final comments. I agree with Dr. Smith. The diagnosis when you consider the serologies, we need to take another test, after to the first diagnosis, But clinically, histopathology and response of the treatment is suggested to Lyme disease, for us, And the idea is follow to the patient in the outpatient clinic in Clinica Utrecht.
Sure, it'll all become clear when you're in the next time round. And the good news is he got better.
Okay. No, yes. Good news we have. We will have.
I don't think there is any other question. So if that is the case, in the interest of time, thank you so much, everybody, for your participation. And we'll see you again in 4 weeks. Take care. Have a nice week.
Bye-bye, and thank you. Thank you.
Thank you. Bye.